integrated surveillance strategy for infection prevention and control and antimicrobial stewardship. But before I continue, I just want to use the opportunity to thank the conference organizers and the Infection Control Africa network for this opportunity. So today we're going to cover the rationale and a practical approach to integrated surveillance, and I'm going to go through some types of surveillance and what I think is important for us to concentrate on coming from low to middle income countries, and our resources and so forth might not lend itself to elaborate forms of surveillance. But we do know that an integrated approach is absolutely crucial. So surveillance is not easy. It can be very challenging, but it's an absolutely crucial component of healthcare. The short-term objectives of surveillance include the importance of identifying and tracking hospital-acquired infections, antimicrobial trends. We want to detect outbreaks and respond promptly and appropriately. We want to evaluate our interventions, and then I think one important component of surveillance is to inform evidence-based policies and guidelines. And we do know, and I'm sure you've heard it over and over yesterday and today, that antimicrobial resistance is a huge threat to human health, and now is not the time to drop the ball on important interventions that can make a huge difference in reducing antimicrobial resistance. So in IPC specifically, there are various types of surveillance, which can include sentinel surveillance, where we monitor specific infections, pathogens in very select patient populations. We can do passive surveillance, where there's voluntary reporting of infection by healthcare staff. But I think there are pros and definitely cons of various surveillance strategies. For example, with passive surveillance in our setting, reporting often doesn't happen, and you get a false sense of that. For example, the HAI rates are very low, but it's actually just that it's not being reported. Active surveillance is more proactive surveillance, where there's identification of infections, and through regular screening and data analysis, but this is labor intensive and you need a huge workforce, and it's very, very difficult to do in our setting. Electronic surveillance is awesome, where you can use existing electronic records, laboratory data and automated algorithms, but the limitation there is that you're only as good as the data that is imputed into the record. And so this data also needs to be taken with a pinch of salt, so to say. And then I'm going to touch on point prevalence surveys, and specifically global point prevalence surveys, which is actually a very, it's a low-hanging fruit to get data in a setting where the healthcare burden is very high and staff resources and time is low. And then if we look at antimicrobial stewardship surveillance, we can look at utilization surveillance, prescribing practices and usage. Resistance surveillance can be used by tracking AMR patterns in pathogens. Pharmacy-based surveillance using pharmacy data to identify trends in antimicrobial use. And I can say we had a National Health Laboratory Service huge national cyber attack where our unit stopped getting information on alert organisms, and we actually ended up utilizing pharmacy data on reserve and watch antimicrobial usage to guide IPC interventions, for example, finding the patients that are prescribed carbapenems and so forth, and ensuring that IPC interventions are in place. One advantage of using pharmacy data for stewardship for IPC purposes is that you find the patients that have culture negative hospital acquired infections, and you can actually intervene early. Lab-based surveillance has pros and cons, but we can use that as well. Clinical surveillance, by looking at what patient outcomes and so forth, is very, very, very labor intensive. You need resources for this types of surveillance. So as I've mentioned, there are challenges. I think the biggest in our setting on the African continent and even South Africa is that we have very little personnel, infrastructure and funding to do high level or resource intensive surveillance. We have a problem with data quality and standardization, which I think is universal. There is still limited access to diagnostic testing and antibiotics, so you may not get a true reflection when looking at data. Our systems can be quite complex, and obviously one needs to take into consideration the evolving nature of pathogens. So there's no one-size-fits-all surveillance strategy, and there are various factors that would make a specific surveillance option feasible. Depends on what your healthcare system structure and capacity is, what the local disease burden is, what the resources are like. And it's very important to have political will and commitment. In our setting, we do have challenges with technological advancements and infrastructure, which limits the intensiveness of the surveillance that we can do on a day-to-day basis. So we try to keep things simple based on the resources that we have. So an integrated IPC surveillance strategy in a resourced area would utilize things such as electronic health record integration, sharing data between different health information systems. We would use data analytics with the application of statistical models to identify trends, and even use things like machine learning and algorithms to predict infection risk and antimicrobial resistance. But this is obviously a challenge in a low to middle income setting because of lack of resources and staffing. And so for our setting, what we would do is a more context specific but resource efficient approach. So what is actually best for a low to middle income setting? And I'll show you a South African case study of what we've managed to do. So what we want from an integrated surveillance approach is that we combine IPC and AMS data, which will give insights into healthcare-associated infection rates, antimicrobial resistance patterns, and antimicrobial utilization. And I'm going to go through some data from a surveillance report that was done successfully, I think, in South Africa. We managed to integrate IPC and AMS data, and this is the most recent one that was published in 2024. So just to give some background, we've got political will, we've got an AMR strategic framework, with strategic objectives which include diagnostic stewardship, enhanced surveillance, which has shown improvement from report to report. It covers antimicrobial stewardship as well as infection control. So what did we find? So when we look at antimicrobial resistance patterns, and this was data from public and private sector laboratories, and they reviewed blood cultures for the escape pathogens in the country. Klebsiella pneumoniae was the most common. Of concern is that 70% of Klebsiella bloodstream infections are non-susceptible to third-generation cephalosporins. Staphylococcus aureus, under 20% are non-susceptible to cloxacillin. 25% of E. coli are non-susceptible to cephalosporins, and so forth. And so if we look at trends year on year, Klebsiella pneumoniae seems to be a huge problem in South Africa in terms of escape pathogens. Our Staphylococcus aureus or MRSA rates looks like it's declining. I think, this is 2022 data, but I think most recently our Acinetobacter baumannii bloodstream infections might be rising. So even though the burden of escape pathogens in terms of total number of positive blood cultures appear to be increasing, the total number of consecutive blood cultures tested increased year on year. So in other words, the percentage of escape organisms actually remained constant from 2018 to 2022. And then we reported on antimicrobial usage data for South Africa, which was estimated to be at 17.9 defined daily doses per 1,000 population per day, which is slightly higher than other BRICS countries, which range from 8 to 15 DDDs per 1,000 population, but it's actually still far lower than high-income countries, which have an antimicrobial usage rate of 20.8 DDDs per 1,000 population. It was also much less than other African countries, namely Algeria, which was 36.8, Tunisia 38, Egypt 24, and Tanzania, which was 25. We also reported on consumption according to Access Watch and Reserve groups, and of concern is access utilization is at around 40+%, which is under what we want. We want it much more closer to 60%. Watch utilization is far higher than what we want it to be, especially in our private sector. So some valuable data. So what made this most recent report refreshing was what was the more integration part, integrating IPC and AMS. And to date, there had been no national surveillance of HAIs in South Africa. And so the IPC Technical Working Group of the Ministerial Advisory Committee for Antimicrobial Resistance collaborated with the University of Antwerp, Belgium, for South African state hospitals to participate in the Global Point Prevalence Survey to look at the rate of HAIs, antimicrobial prescribing and usage. And the GPPS has an optional HAI module, which South Africa used, that gave valuable insights into IPC application and antimicrobial usage related to HAI. South Africa's global point prevalence study, the first national one, was led by Professor Shaheen Mehta and one of my colleagues at Tygerberg, Dr. Heather Finlayson. We started off with a pilot study of 6 hospitals, and my hospital was one of those, and this served as a very steep learning curve and proved very useful when the first national study was done in 2023. In 2023, data from 52 sites was collected, and these were mainly public hospitals across all 8 provinces. And of the 8,500 plus patients, almost a third or just over a third were on antibiotics on the day of collection. Of concern is that almost a half of pediatric patients were on at least one antibiotic on that day. Very high antibiotic use as expected in the ICU groups, ranging from 45 to 79% in the various categories of ages. But for the first time, we actually managed to get an HAI rate for the country, which was sitting at 7.15%. Of this, 1.5% was due to surgical site infections. HAIs such as UTIs and pneumonias and so forth contributed 3.7% of that 7%. Most of the infections were in the neonatal setting. What was interesting is that HAIs were higher in the medical ICUs, and in the surgical ICU, surgical site infections contributed to almost a half of the HAI rates. Of the 8,500 plus patients, 41% had a peripheral line, almost 5% had a central venous line, and almost 15% had an indwelling catheter. So this is data that we haven't had before, and of concern, and what I can see from other GPPS results, including that from India, is that the duration of surgical prophylaxis was longer than the guidelines recommended. In our study of the 250 surgical patients, a single dose of antibiotics was only admitted in 19% of cases, and almost 70% of patients received more than 1 day of therapy, which is a low-hanging fruit for intervention based on the guideline. So in a setting where there is low resources and minimal staff, I would definitely recommend performing a point prevalence survey. There are obviously pros and cons of each study methodology. With a PPS, you're obviously just getting a snapshot, but if you do it at multiple sites, you actually get valuable data that could be good opportunities for intervention. One needs to plan for this. You need at least a 9-month lead time. All the people involved will need focused training and dedicated time to do the data collection. Our colleagues in Uganda compared the WHO PPS and the global PPS, and the GPPS is designed to be a bit more uncomplicated and freely accessible, and I think the advantage of incorporating IPC data into the stewardship tool does have its advantages. So what is the future of surveillance? I would think that we are probably still in step 1 and 2. We always start off with basic surveillance. We develop it and expand our surveillance scope. But what the future is that we want more advanced surveillance with real-time information and feedback, and the optimal type would be where you have integrated data and that it's automated. But unfortunately, in our setting, we haven't reached that level of automated surveillance, but one needs to work towards the future and keep optimal strategies in mind. So to summarize, the components of integrated IPC and AMS surveillance would include data on healthcare-associated infections, antimicrobial utilization monitoring, AMR patterns, and then one thing that we don't have nationally but that we do is hand hygiene and infection control practice surveillance, and that is something that we've also been discussing. Is it worth it to potentially have a hand hygiene dashboard, link it up with AMR patterns and so forth. So lots of exciting things to look at in the future. So an alert organism report is not surveillance. It has several limitations. Otherwise, you're going to inappropriately use or interpret the data. It definitely does not represent healthcare-associated infections. The samples that are collected are not necessarily standardized. You wouldn't know if the infection was hospital or community acquired. Some of the specimens may actually reflect colonization or even contamination and not true infection. And so it's definitely not surveillance data. And the reports don't have a denominator data, so you wouldn't know how many specimens were submitted, total number of patients that were sampled, or even the total number of patients admitted. So one would have to add all of that data to make the alert organism data interpretable in terms of HAI rates and so forth. And so that is the limitation to what we have on a daily basis, and that is why using a point prevalence study is actually quite beautiful, because you can do it year on year and monitor trends, and you get reliable real-time data, and it wouldn't be a strain on your human resources. So to end off, for those of you who are daunted by surveillance, I would recommend keeping it simple. Start small. We can't all do big national projects, but you can begin with a pilot project or a small-scale surveillance system focusing on one specific healthcare setting, for example, the ICU. Monitor a limited number of indicators as a start. Try to use existing data sources if it's available, and then you gradually expand your scope and complexity based on the lessons that you've learned from your small project. In our setting, I've decided to focus on high-impact interventions, and these are interventions where there's evidence base for effectiveness, potential for significant impact on patient outcomes, and I think in my hospital it's a bit more feasible and practical, and it aligns with our disease burden and it supports our national priorities. I think it's important to remember what the end game of surveillance is. We want to eliminate healthcare-associated infections, optimize antibiotic use, prevent and control antimicrobial resistance, and above all, improve patient safety and outcomes, and then additionally reduce healthcare costs. So while we're busy with surveillance, we must not forget to implement our high-level interventions so that we can make a difference. There's no point in studying without using the results to try to make improvements from year on year. So in my final slide, I'm going to end off with some lessons learned. You must have realistic expectations. It's best to keep it simple, start small and scale up gradually. I would recommend prioritizing high impact interventions, ensuring that you have synergy between IPC and AMS wherever possible, and engage local stakeholders and experts. Ensure that you have data quality and standardization. Rather do a smaller project or simpler project but have data that is a bit more robust or reliable. Remember that there's no one size fits all. You're going to have to look at different sort of methods of surveillance. Don't forget about the end game. Why do we do this? We want improvement. And so you have to act on your surveillance results. Always continue evaluating and improving as you go along. Thank you so much.
Very much, Dr. Parker. First of all, I would like to congratulate you with your recent PhD. That is what I understand, and heartiest congratulations for that. And today's lecture, I think, it is so practical, so guiding that just by going through your presentation, I think, the people will be able to know how to go about the surveillance, the A, B, C, Ds. I think, you have put it so lucidly, so practically. I think, this is going to make a lot of difference for those who are aspiring to have HEA and AMS surveillance. That's a wonderful work. And one of the things, what I have noticed from your study, you have 7.15% as your HEA rates. That's, I think, for a kind of global South nation, I think, this is a very, very good parameter. I think, that is mostly thanks to you and your colleagues, who are doing an excellent job in terms of preventing the healthcare associated infections. I also noticed that a very, very important thing, I don't know, it is only because you have a very small selection of the hospitals who already have good practices, or, I don't know, what was your study design and how many institutions participated, but if I look at the pattern of the prescriptions from the AWARE classification, 64% access drugs being prescribed, that is something really wonderful. Of course, we should aspire for 80%, but that's a great beginning, 64%. I think, I should congratulate those institutions who are doing such a great job, both in terms of HEI prevention and also the antimicrobial stewardship practices. It's really very heartening to see. I have one small doubt, right? Why did you choose, this platform, which is PPS platform? Is it because you were working with this Antwerp University or the institution, who have developed, or what was the reason? And what is your personal feeling between the WHO, PPS, and this particular tool? What is better for those people who have a very limited access to the digital technologies and the access to probably bandwidth of internet? What would be your call? And, that could be a good advice for a lot of people.
I think the rationale for using the Global Point Prevalence Survey was the interaction with the University of Belgium or Antwerp. And I think they were very, very supportive. The tool is actually very, very easy to use. So in our hospital, we had a group of myself, infectious diseases specialists, the microbiologists, the pharmacists, the infection prevention and control team, and we split up the hospital, rotating internal medicine registrars, and we went from bed to bed and captured information. The advantage over the WHO tool is that we had some IPC data. I think it still needs a bit of refining. We captured on tablets, so we've done paper before, but it was actually very nice to capture on tablets in our hospital. Other centers would do paper and then put it into a computer thereafter. And the beautiful thing is that you get results back that you can compare to other hospitals in the country, other hospitals on the continent, and other hospitals around the globe. So, so for our hospital, for example, the HAI rate was about 6.8 or 6.9. And then it was around 51 hospitals, a mixture of well-staffed or low-resourced and well-resourced. And yeah, so it was a very comprehensive project, and we had data from the whole country, which we've never actually had before. So it was awesome. It was really a good experience, and the advantage is we can do it year on year during the same time period and improve as we go along with feedback from everyone that did capturing and so forth. And yeah, I really think that the one opportunity for intervention is that we need a standardized surgical site prophylaxis guideline, because I think it's a very universal problem. I saw the abstract from India that was discussed at ECMID, and it is a challenge in our setting. It's a challenge in my hospital. We've actually done visits to the surgeons and the orthopedic surgeons, and there isn't consensus. So the anaesthetist said they write up what the surgeon tells them. The surgeons tell us, oh, they don't have a specific guideline. So there's definitely something that we can take forward.
Thank you very much, for those really great insights, which are very practical, which are really going to make a lot of difference for those who are aspiring to improve their practices. And as you rightly said, I think, we should start small rather than trying to embrace everything. I think, you should go step by step. That's a very good suggestion. I think, a lot of those, colleagues, who are aspiring, I think, they will take this as a good advice. And congratulations both with your PhD and also with the great work what you have done. And looking forward to see you sometimes. Thank you very much on behalf of all the organizers of G-SPARC. And as a chair, I am indebted to all of you, for making your time to share your knowledge and experience for improving IPC and AMS practices. Thank you very much. Have a great day.